I'm Rebecca Broyles, co-owner and educator for the Coding Corner Medical Coding Education. Today we're going to talk about GI Coding Unlocked, navigating the nuances of gastroenterology procedures. Introduction to GI Coding. GI coding is detail heavy and documentation dependent. Intermediate coders should already understand CPT structure and modifier basics. This session builds on that foundation. GI coding requires a mastery of anatomy, procedure intent, and hierarchy rules. Some common procedures are colonoscopy, EGD, ERCP, and EUS. Documentation drives the code selection. GI coding spans diagnostic and therapeutic endoscopy of the upper and lower GI tract. Documentation quality directly impacts code selection and compliance. Think clinically as well as technically. GI anatomy isn't just clinical, it directly impacts code choice. For example, reaching the terminal ileum changes colonoscopy coding. Coders must visualize the anatomy to understand procedural intent. The upper GI is from the esophagus to the stomach to the duodenum, which is the first portion of the small intestine. The lower GI is the colon to the rectum to the anal canal. A coder must visualize the anatomy to understand what the physician actually did. For example, reaching the terminal ileum during colonoscopy may support a complete exam. In an EGD, reaching the second portion of the duodenum is typical. Going further may indicate an enteroscopy. So the extent of the exam determines the CPT code family. You need the access route, oral versus rectal, which defines whether the procedure is EGD, colonoscopy, sigmoidoscopy, so forth. And landmarks matter. Cecum, terminal ileum, and the second portion of the duodenum. You should be familiar with these terms. Colonoscopy coding essentials. You need to always choose the highest valued code. And remember that screening is a payer concept, not a CPT code. Screening versus diagnostic versus surveillance. The CPT hierarchy is diagnostic, then biopsy, and removal. Some key documentation elements are the extent of the exam, technique such as snare, cold biopsy, hot biopsy or EMR, and the number of lesions. Remember that CPT codes describe what was done, not why. The why is captured in ICD-10-CM. Screening versus diagnostic versus surveillance. The screening is for an asymptomatic, age-based or risk-based patient, not showing any signs or symptoms, just to screen to be on the safe side. Diagnostic is when symptoms or abnormal findings occur. And surveillance is when the patient has a history of polyps or another type of disease. Technique documentation is essential for correct code selection. The CPT definition of a colonoscopy is the exam reaching the cecum or beyond. If the scope does not reach the cecum, the procedure may be coded as a sigmoidoscopy or an incomplete colonoscopy. The hierarchy goes diagnostic to biopsy to removal. Some colonoscopy examples. The screening colonoscopy converted to polypectomy by snare technique. The CPT code would be 45385. You would use the ICD-10-CM code of the Z12.11 and a code for the polyp finding, but you would also add the modifier 33 for commercial or the modifier PT for Medicare patients to show the screening colonoscopy was converted to a diagnostic. 45385 overrides the screening intent. Next, you see a diagnostic colonoscopy with code biopsy of 2 polyps. You would choose CPT code 45380. You would only code this once per session, not per lesion. Payers may have different interpretations, so documentation must clearly state the reason for discontinuation. So for complete colonoscopy rules, if the scope does not reach the cecum due to patient factors, use a modifier 52. If discontinued due to extenuating circumstances, use modifier 53. If the scope reaches the cecum but the procedure is not completed, it is still a complete colonoscopy. EGD coding fundamentals. You have your base code 43235, which is diagnostic. You will also have add-on codes for biopsy, dilation, control of bleeding, or foreign body removal. Documentation must specify the extent, such as the esophagus, stomach, or duodenum, and the interventions performed. EGD coding is more straightforward than colonoscopies, but they still require attention to detail. Understand that visualization only is diagnostic unless intervention occurs. Some add-on or alternative codes can be biopsy 43239, dilation, control of bleeding 43255, foreign body removal 43247, or polypectomy 43251. An EGD coding example, we have EGD with gastric biopsy. The correct code would be CPT 43239. EGD with control of bleeding in the duodenum. The correct CPT code is 43255. Remember that control of bleeding codes are used only when the bleeding is not caused by the procedure itself. ERCP coding overview. ERCP stands for endoscopic retrograde cholangiopancreatography. It is a procedure used to diagnose and treat problems in the biliary system, which includes the bile ducts and pancreas. ERCP codes are bundled by ductal system, the biliary, pancreatic, and accessory. Documentation must specify which duct was treated. Some common interventions are sphincterotomy, stone removal, stent placement, and dilation. Multiple interventions may be coded if performed in different ductal systems. Some ERCP examples: biliary, sphincterotomy, plus stone removal. The correct CPT code would be 43262. The stone removal includes the sphincterotomy. Pancreatic duct stent placement. The correct CPT code is 43274. Endoscopic ultrasound or EUS coding. The codes vary by anatomic region, esophagus, stomach, duodenum, and rectum. EUS is often misunderstood. Understand that FNA or fine needle aspiration is not inherent to EUS and must be documented clearly. If the FNA is separately coded, some examples would be the 43238 plus 10004 through 10006 if the documentation supports. The documentation must include the region examined, whether FNA was performed, the number of passes for pathology, and the lesion location. Remember that EUS is often paired with the FNA, but they are not inherently bundled, and the importance of linking the FNA to the correct anatomic site. Modifiers in GI coding. 33 for preventative service. These are used for commercial payers. PT are preventative services screenings converted to diagnostic for Medicare patients. 59 or XS for distinct procedural service. And 52 reduced services such as incomplete colonoscopy. Some common documentation pitfalls: missing extent of the exam, such as colonoscopy performed without cecal landmark, unclear technique, snare versus cold biopsy, no lesion count or location, no ductal system specified for the ERCP, or missing medical necessity documentation for diagnostic procedures. Make sure to query proactively. Poor documentation leads to undercoding or denials. Some additional case studies: ERCP with biliary stent placement plus pancreatic duct dilation. The CPT code would be 43276 for the biliary stent and 43266 for the pancreatic dilation. EUS of rectum with FNA of perirectal mass. The CPT would be 45391 for the EUS and 10005 for the fine needle aspiration. Some key takeaways: GI coding requires strong clinical understanding and attention to detail. Hierarchy and bundling rules are essential for accurate CPT selection. Modifiers must be applied correctly to maintain compliance. Documentation quality determines coding accuracy, and when in doubt, query your provider. GI coding is high stakes and high scrutiny area that requires continuous learning. Thank you. Please visit us at www.thecodingcornermce.com.